Being able to diagnose the innominate is pretty simple when you compare it to being able to diagnose the sacrum. You only need to know where the landmarks are in relation to one another to get the question correct. In this lecture, I'm going to walk you through how to get the correct diagnosis based on where the landmarks are. We're going to use a simple hand gesture to get the correct diagnosis. Then at the very end, I'm going to include a flowchart for people that like flowcharts. So if you take a look at the picture, on the anterior side of the innominate, you have the anterior superior iliac spine, or the ASIS. On the posterior side of the innominate, you have the posterior superior iliac spine, or the PSIS. Back on the anterior portion of the innominate, you have the pubic tubercle. You are going to use these three landmarks in order to get your innominate diagnosis. So we're going to use those landmarks to get the correct diagnosis for the innominates. So the first thing that you need is the standing flexion test. Now the standing flexion test is basically the same test as a seated flexion test, except instead of having the patient seated, they're going to be standing up. So don't get confused between the seated flexion test and the standing flexion test. The seated flexion test is only for the sacrum. The standing flexion test is for the innominates. So what we're going to do is we're going to have the patient standing. We're going to hook our thumbs below the PSIS and have the patient bend forward into flexion. As they go into flexion, one of our thumbs is either going to move first, furthest, or fastest. Whichever side does that is going to be your positive side. That's going to be the side of dysfunction, and that's what you're going to name the diagnosis from. A test that's similar to the standing flexion test is called the ASIS compression test. This test tells you the same thing as the standing flexion test. It just says which side is positive. The way that you perform this test is you have the patient laying on their back, supine, and you take both hands and you push posteriorly on the ASIS. Whichever side is more mobile is going to be the positive side, the positive compression test. You can compress it more. So then back to landmark anatomy for what you need to make the diagnosis. You have the ASIS, and there are 4 different findings that you can have for the ASIS. It can either be superior, it can be inferior, or it can be medial or lateral. All of these findings are in relation to the ASIS on the other innominate bone. So if the ASIS on the right side is superior, that means that the ASIS on the left side is inferior. Now the next landmark is the PSIS, and you can have the exact same findings for that. It can either be superior, inferior, medial, or lateral. So these are once again in relation to the other innominate PSIS. So if the PSIS on the left is inferior, that means that the PSIS on the right is superior. The last landmark that you have is the pubic tubercle. The pubic tubercle can either be superior or inferior in relation to the other. So if one is inferior, the other is superior. So there are 3 different types of dysfunctions that you can have for the innominates. You can have rotations, shears, and flares. So we're going to go over rotations first. A rotational dysfunction means that one of the innominants is rotated further than the other. You can either have an anterior rotation, meaning that it tips anteriorly, or you can have a posterior rotation, meaning that it tips posteriorly in relation to the other. So if you have an anterior rotation, you're going to have these landmark findings. Your ASIS is going to be inferior on the side of the standing flexion test. Your PSIS is going to be superior on the side of the standing flexion test. When you have an anterior rotation, you are also going to have a longer leg on that side. So think about this anatomically. If the innominate is rotated anteriorly, you're pushing the rest of the bones downward, so you're creating a long leg. Long leg. So what's one item that can cause this dysfunction? You can have hypertonic quads. So think about this anatomically. Your quads are on the anterior portion of your thigh. They attach to the anterior portion of your innominate. If they're hypertonic, they're going to yank down the rest of the innominate, causing a forward bending or an anterior rotation. So then how do you treat it? You're going to do the opposite. So what are the antagonist muscles to the quads? You have the hamstrings. So the hamstrings are located on the posterior side of the innominate. If you need to pull the rest of the innominate back into posterior rotation, you're going to treat the hamstrings with muscle energy. You're going to activate the hamstrings, pull that anteriorly rotated innominate back posterior. So you're going to treat with the hamstrings. The quads can cause an anterior rotation. You're going to fix it with the hamstrings. So now you have a posterior rotation. Basically, the exact opposite of an anterior rotation. So your ASIS is going to be superior on the side of the standing flexion test. Your PSIS is going to be inferior on the side of the standing flexion test. You're going to have a short leg. It can be caused by the hamstrings, and you can treat it with the quads. It's the exact opposite of the anterior rotation. So you have anterior and you have posterior. So I'm going to leave a gap here so that we can come into some practice questions a little later on. But the next type of dysfunction that you can have is a shear. Now a shear is basically where one of the innominants is located either superiorly or inferiorly compared to the other side. So you can have a superior shear or an up shear, or you can have a down shear or an inferior shear. So what are your findings going to be for this? So for an up shear, you're going to have an ASIS that is superior on the side of the standing flexion test. You're going to have a PSIS that is also superior on the side of the standing flexion test. And you may even have finding of the pubic tubercle, which would also be superior on the same side as the standing flexion test. So how do we relate this to the leg? Imagine that you have an innominate that's up higher. It's going to pull the rest of the bones with it, so you can imagine that you're going to have a short leg on that side. So a short leg. So if you have an up shear, that means you can also have a down shear. In a down shear, the findings are exactly the opposite as an up shear. So you have an ASIS that is inferior on the side of positive standing flexion test. PSIS that's also inferior, and a pubic tubercle that is also inferior. The leg length is going to be long. So imagine that the bones are being moved downward, you're going to have a long leg. There are two other types of shears that you can have. You can have a pubic up shear and you can have a pubic down shear. So you can have two other types of shears. You can have a pubic up shear and a pubic down shear. So these findings are very easy to point out. Your pubic tubercle on a pubic up shear will be superior. On a pubic down shear, your pubic tubercle will be inferior. But what about ASIS and PSIS? They're not going to have any landmark findings. So it's only going to be the pubic tubercle that has something. Same thing with the down shear. ASIS, PSIS, nothing. Pubic tubercle will be down for down shear on the side of dysfunction. And the last type of dysfunction that you can have in the anonymous is a flare. There are two types. You can either have an in flare or an out flare. That means that one innominate bone is either tilted more inward as an in flare or tilted more outward as an out flare. So for these findings, in flare, your ASIS is going to be medial on the side of dysfunction, and your PSIS will either have no findings at all or will be lateral. And for an out flare, the theme of being opposite, it's going to be the exact opposite. So you have an out flare, your ASIS is going to be lateral on the same side as your standing flexion test being positive, and your PSIS is either not going to have any findings or it's going to be more medial. So now I have all the findings. How am I going to be able to use this to get the diagnosis without memorizing all of these tiny points? This is where the cowabunga hands is going to come in handy. So let's go ahead and write down a practice question. So for number 1, we're going to have a standing flexion test that's positive on the right, an ASIS that is inferior on the right, and a PSIS that is superior on the right. So this is where your cowabunga hands are going to come into play. You can hold them directly in front of you. Your thumbs are going to be the PSIS, and your pinkies will be the ASIS. So what you're going to do is you're going to use the anatomic findings in order to get the correct diagnosis. So for these dysfunctions, remember that you always name the side of the standing flexion test for your diagnosis. So all of your diagnostic findings need to be on that side in order to get the cowabunga hands to work properly. So in this example, the standing flexion test is positive on the right side. The ASIS is located inferiorly on the right compared to the left. So I'm just going to twist my hand forward. So now the pinky is lower than the other pinky. The PSIS on the right side is superior on the right, more superior than the PSIS on the left, which is still where I'm holding my hand. So if I'm looking at this, I can already tell that the right innominate is anteriorly rotated. So the answer is right anterior rotation. So then the second question, let's say that you have a standing flexion test that's positive on the left, an ASIS that's inferior on the right, and a PSIS that is superior on the right. So I just use my cowbunga hands once again. You have a positive standing flexion test on the left, so you're going to name everything based on the left side, which is the abnormal side. On the right, you have a inferior ASIS, but a superior PSIS. Now the findings are on the other side than the standing flexion test. The standing flexion test is the dysfunctional side and the abnormal side. So you have to reverse it. So you move your fingers back into the regular anatomic position so that now my right side, which is normal, is back in the normal plane, and the left side is now dysfunctional. So now when I'm looking at my hand, I can tell that my left side has rotated posteriorly. So the answer is a left posterior rotation. So the next practice question. You have a compression test that's positive on the left, an ASIS that is inferior on the right, and a PSIS that is inferior on the left. So remember, the compression test is the same thing as a standing flexion test. This just tells you that your findings are abnormal on the left side. So you need to relate all of the findings back to the left innominate. So your ASIS is inferior on the right side. So you rotate your right hand downward to get your pinky inferior. PSIS is inferior on the left side. So you rotate your hand left. So to get the diagnosis, you have to bring your right hand back to neutral because the left side is dysfunctional. So now that you have your hands like this, you can tell that your left hand is posteriorly rotated. So you have a left posterior rotation. So let's do some practice questions for shears. So the first question, your standing flexion test is positive on the right. Your ASIS is superior on the right, and your PSIS is superior on the right. So if you're doing your cowabunga hands, once again, you have to make sure that all of your findings are on the side of dysfunction, which for this example is going to be for the right. So now using the cowabunga hands, you have your standing flexion test that's positive on the right, which means that all of your diagnostic findings will be on this side. Your ASIS is superior on the right, and your PSIS is also superior on the right. So using this motion, you can tell that the right side is up. So you have a right up shear. Right up shear. Next question, standing flexion test, positive on the right. ASIS is superior on the left. PSIS is superior on the left. So using your hands, the right side is dysfunctional. Left ASIS is up, left PSIS is up. Your findings are on the right side, so the right is dysfunctional. If you're looking at it, the right is now lower than the left. The answer is a right down shear. The final shear practice question. You have an ASIS compression test that's positive on the left. You have a pubic tubercle that is superior on the right. You have an ASIS finding of being normal, in a PSIS finding of being normal. Can't really use the cowabunga hands for a pubic up shear or down shear. Just memorize that if the pubic tubercle is up and everything's normal, it's pubic up shear. If it's down, pubic down shear. So for this one, you got a pubic up shear. So now some questions for a flare. You have the standing flexion test that's positive on the right, and you have an ASIS that is medial on the right. So cowabunga hands, positive on the right side. Your right ASIS is more medial. So when you're doing this motion, you can tell that your right side is going inward. So this is a in flare on the right. So a right in flare. So the standing flexion test is going to be positive on the left, and your ASIS is going to be medial on the right. So back to using your hands. The left side is dysfunctional. The right ASIS is located more medial, but you have to bring it back out to neutral so that it makes sense. So when you bring it to neutral, you're going to show that now the left side is an out flare. So bring it back in neutral. So a left out flare. So if the cowabunga hands made sense to you, then you don't really have to worry about anything else and the lecture's over. But if you're the type of person that likes a flow chart and just wants to be able to take the points that are given to you and plug it in somewhere to get the answer, we're going to do a quick flow chart for that. So in order to do that, so the first thing that you're going to do is compare the direction of the ASIS and PSIS on the same side as one another. So your ASIS can either be superior, inferior, and your PSIS can be superior, inferior. If you've noticed, for shears, the ASIS and PSIS are both superior, or for a down shear, the ASIS and PSIS are both going inferiorly on the same side. If you have a rotation that's anterior, the ASIS and PSIS are both located on the same side but pointing in opposite directions. For a posterior rotation, the ASIS and PSIS are pointing in different directions but on the same side. So if we're going to use that for our flow chart, you're going to assess which direction the ASIS and PSIS are both pointing on the same side. So if they are both pointing superior or both pointing inferior on the same side, you're going to have a shear. Now if on the same side the ASIS and PSIS are pointed in opposite directions, that's going to tell you that you have some sort of a rotation dysfunction. So the next thing that you're going to do is compare the standing flexion test and the side of the superior ASIS. So if you're on the shear side, you have a standing flexion test that's positive on the same side that the ASIS is superior, you're going to have an up shear. If it's located on opposite sides, so let's say the standing flexion test is positive on the left, but the superior ASIS is located on the right, that means that you're going to have a down shear. So now looking back at rotations, you're going to do the same next step. You're going to compare the standing flexion test versus the side of the superior ASIS. If the standing flexion test is positive on the same side as the superior ASIS, you're going to have a posterior rotation. If the side of the superior ASIS is on the opposite of the side of the positive standing flexion test, you're going to have an anterior rotation. So we went over two different methods of diagnosing the innominate during this lecture. We went over the cowbunga hands and we went over the chart. The only other thing that you need to do is assess which side the standing flexion test is positive, the ASIS location, the PSIS location, and the pubic tubercle location. And that's how you diagnose the innominate.